Hello, everyone. My name is Alexa, and welcome to Nurses Notes 101. So today we'll be talking about the first topic in the CCRN, which is cardiovascular disease, treatments, and procedures. So the first component of this is acute coronary syndrome, also known as heart attack. I'm going to talk about NSTEMIs, STEMIs, and unstable angina, the difference between them, and how to treat them. An NSTEMI is a type of heart attack that does not have an identifiable ST elevation in the EKG. So when a patient comes in, the first thing we always do is do an EKG when someone has chest pain. If it appears that there is no ST elevation after the PR interval, but they do have cardiac enzymes, then it's considered an NSTEMI. So an NSTEMI usually occurs when a ruptured plaque either completely blocks or partially blocks a coronary artery. The signs and symptoms of this is usually in the EKG. While we cannot see an ST elevation, the EKG shows a T wave inversion, ST depression instead of elevation, and then the patient will have shortness of breath, chest pain, sometimes irritation in the neck, or stomach pain or back pain. On the other hand, a STEMI is when a patient comes in and they do have ST elevation on their EKG. So this is usually from more of a detrimental blockage, a complete coronary artery blockage. These patients are at higher risk of developing life-threatening arrhythmias like VFib, which can cause cardiac arrest. The patients who have STEMIs, they have the same signs and symptoms as an NSTEMI, but the only thing different is the EKG showing ST elevation. Like I said in the previous bullet point, is that with a STEMI, it is more dangerous for the patient because they're more prone to going into ventricular dysrhythmias, which can cause cardiac arrest. Unstable angina is probably the least severe of the three. Unstable angina is usually just caused by coronary artery disease, usually atherosclerosis. Unstable angina, while it is still unpredictable, and usually the side effect of this is chest pain, and this chest pain will continue despite rest. The warning signs of unstable angina is tightness in the chest. One of the most common medications to relieve unstable angina would be nitro. If you have taken multiple doses of nitro, usually given sublingually, and chest pain is still there, then the most important thing next would be to go to the hospital. As for treatments, the first line of treatment for either three of the acute coronary syndromes is aspirin. Usually we will give 300 milligrams, and most of the times physicians will say to chew it because the mode of action will be faster for the patient. So they'll get that antiplatelet effect faster. And then when in the hospital, these patients are usually started on heparin to keep their blood thin and to promote the unblockage of that artery. If the physicians see that this is an option, a lot of times these patients can also get thrombolytics. So this is a clot busting medication that's used to dissolve the clot, blocking the artery. Examples that we usually see is TPA. Nitroglycerin, like I said before, is a medication that's usually used with unstable angina in either of the three. The only thing you would have to look out for is if the patient is hypotensive. So they would not give in that scenario. If the patient has high blood pressure, complains of chest pain that's unrelieved, and if a physician doesn't think morphine is the appropriate medication, they'll give nitro, and it does promote blood flow because it vasodilates. We will also give antiplatelet therapy to prevent excess clots from forming. These include Plavix or Eliquis, and the patient will sometimes be on these after PCI procedures consistently if stents were placed. Let's say the patient has a massive heart attack, and when they go for their percutaneous intervention, they go for a cardiac cath, and they have multivessel disease. They could be a candidate for a bypass, either a double, triple, or quadruple vessel bypass to promote collateral circulation from other vessels. For example questions, this question reads, patient goes for preoperative evaluation prior to an orthopedic surgery. The cardiac catheterization notes significant coronary artery narrowing in 2 vessels. Which is the most likely intervention? Will the patient get bare metal stents, open heart surgery, or have drug-eluting stents placed, or thrombolytic therapy? So right off the bat, I can knock out open heart CABG. So my understanding of this, if the patient has 3 or more vessels that have significant injury, meaning over 95%, then they would go for open heart surgery, but there's only saying there's narrowing in 2 vessels. And narrowing per se doesn't mean that the vessels are occluded enough for surgery. Thrombolytic therapy is used only in severe situations and in an acute incident. Since the patient isn't having acute chest pain, I would say thrombolytic therapy wouldn't be appropriate. So for you guys out there, I would say A or C would be the better option. Obviously, I know the answer, but I want to see if you guys can come up with it on your own. So give yourself a minute on this question before you move to the next part. All right, so the answer is bare metal stents. So bare metal stents are better suited for patients who are scheduled for procedure due to only 6 weeks treatment of antiplatelet therapy needed. While drug-eluting stents would also assist with the patient's coronary issues, the antiplatelet therapy needed for drug-eluting stents requires 12 months of treatment. So for someone who's pre-op, a bare metal stent is more appropriate. Our second question reads, a patient presents with a STEMI and has a history of a stroke. Which is the usual drug combination to be administered to this patient during a percutaneous intervention? So patient has a STEMI. The key here is history of a stroke. So the medications we have are metoprolol or prasugrel, aspirin or prasugrel, TPA or aspirin, and aspirin and Plavix. So metoprolol, as we all know, is a beta blocker used for hypertension, used to prevent arrhythmias or a fast heart rate. Prasugrel is another antiplatelet medication. TPA is a thrombolytic used for only acute events. So a lot of times after a patient has a PCI, they'll put stents in, and frequently they will use 2 modes of antiplatelet therapy. So with that in mind, what answer do you think is the most appropriate? All right, give yourself a minute here, and then I'll talk about the answer right now. So the answer is D. So dual antiplatelet therapy prior and during PCI is the recommendation by the AHA. Aspirin and Plavix prevent blood aggregation, which in return prevents further clotting from developing. And then just as a tidbit of information, prasugrel is not given for patients with a stroke history. Okay, and that is acute coronary syndrome. Thank you for listening to Nurses Notes 101. Like and subscribe.